Our next session broadens our perspective to the global arena, exploring how trauma system shapes outcomes, policy, and prevention. We'll journey through insights from Australia's trauma system development, learn from the transformative vision of the Qatar Trauma Institute, and examine how major trauma destination policies and multi-system integration in prevention are redefining the coordinated trauma care worldwide.
To steer us through this pivotal session, we are honoured to welcome our esteemed chairpersons. We warmly invite on stage Dr. Iranda Sanjeeva, Consultant Intensivist at the National Hospital of Sri Lanka, and Dr. V.Y. Sabaratnam, Consultant General Surgeon at the National Hospital of Sri Lanka.
Good afternoon. The next sessions will be on trauma systems, and we have three speakers. Since we are running late, I will first introduce Prof. Jeremy from Australia. He is a trauma surgeon as well as a general surgeon with an unusual combination of breast oncoplastic surgery. It is not a common combination. I invite Prof. Jeremy to talk on trauma system development in Westmead, Australia.
Thank you for that. I think actually this talk I gave that talk yesterday. I think right now I'm going to be talking about the importance of standardisation and standard processes of care, I think for today. But again, while we're waiting for the talk, I just want to thank the organisers for inviting me to participate in this meeting. It's been great. It's been really good to see the differing international kind of perspectives on trauma care, and to actually see that there's a lot of common features obviously to it. So hopefully I can share with you some information that you might be able to take to your own practice and integrate it as you can. We're nearly there. I think this must be a sign they're trying to tell me speak even faster, because the countdown is still going. Again, I feel like this is sabotage. Like the program organisers assigned me the talk yesterday as the very last talk before your afternoon tea. And I feel like today it's also a trick, because I've been assigned to a session that is holding you all up from lunch. So thank you very much for staying around and your patience.
The next speaker, Professor Rueben Peralta again, is the Deputy Trauma Medical Director at Hamad Medical Corporation, Qatar, and he's a Senior Consultant and Director of the Trauma Surgical Critical Care Fellowship Program at Hamad Medical Corporation, Qatar. He's going to talk about Qatar Trauma Institute and how it can change the world. Over to you, sir.
Well, thank you again. Thank you for the organizing committee, Dr. Kirti, Dr. Faith, and all the chairs for this great opportunity. Presentation. I'm going to make mine like in 10 minutes. Next presentation, please. My presentation, the second presentation is there.
While we are waiting, can I ask you a question?
Yes.
You have a very diverse community. More than 90% are born outside Qatar.
Yeah.
So in the training, how do you find possible to bring all ethnic communities together?
It's a great question. Actually, this is one of the most beautiful things that I do because we have residents and nurses that are in a war conflict. We have patients and nurses from, for example, from Canada, from the West, from the East, Southeast Asia. But we have a power bank and we have a psychology. The psychology run with us, and every patient is being seen by a psychology. And every patient that leaves the trauma room to the clinic is being seen by the physician first and the psychology next to door. This is a rule that we have established, and I will show you this in the next lecture. Okay? Thank you. So, again, it's a great pleasure. I love the smile. You know, if you're hungry, I love the smile, meaning that you like a little bit of what we're doing. This is my conflict of interest is still I have a passion for education. And as you can see in this picture there is represented all the fellows on the right from like maybe 7 or 10 countries. We have fellows from Gaza, fellows from Libya, fellows from Egypt, from Jordan, Palestinian, and from Iraq. So 60% of those fellows has war conflict right now in their countries. So many of them, they cannot go to the country. Nowadays, the Syrian doctors are going back to Syria because of some development politically, but they couldn't go for decades to Syria. Without telling you that, I think the objective today is to see that the trauma education is probably the pillar that can connect us to the public, to serve our brothers and sisters, is via education, because we have to provide a quality care to those patients. And professional education is a must for any trauma center and for any institution and for any Minister of Health, if there are some politicians about here. And this is what evolution of the Qatar trauma system really has been. You have to also document what we do. We have published, it's probably the first national, completely national trauma system published in the literature. Why? Because when you invest in the other thing in favor, it's a small country. We couldn't cover everything from A to Z. And what I'm trying to tell you is you question everything we base of the 5 or 7 columns that we have for any trauma system. We base in a continuing education and an outreach. We have to educate our colleagues and nurses and psychologists from other hospitals and refer patients to us. And you can see you start with the continuing education, you go to some clinical research because we are based in the Qatar and the trauma register. We base also in quality improvement. We have the injury prevention program as a social responsibility of the trauma system. And also we have included the families and then communities. And the families and communities, that's why the psychology and the case manager are. We provide MDT, multidisciplinary trauma, teen family members every week, 1 or 2 a week to every patient and the trauma that goes to the ICU and also on the floor. As you can see, this is what a Qatar trauma system is. we're going to focus a little bit today is how do we get there, how to accomplish excellence, is through continued education and outreach. Trauma centers is a community resources. That's why when I mentioned the National Hospital is a trauma center probably from Sri Lanka. It's an incredible for patient care. It's a source for information for the authorities to use seatbelt, not to use seatbelt, to really work in difficulty at night in buildings and so forth. And it serves as a public awareness, as an injury prevention education, and also a professional education for nurses, paramedics, physicians, and allied healthcare, including for the fire department and also for the police. All verified trauma centers must engage in public and professional education. And that's what I'm going to bring to you, what is our Trauma Critical Fellowship has been there. When they recruited me from Dubai, I was in Boston, I went to Dubai, and then they recruited me to establish this program in Qatar. They asked me this question: why we need a Trauma Critical Care Fellowship program in Qatar? We are rich. And I say, well, many reasons. Let's check ourselves. And ourselves was trauma was leading cause of death in Qatar. As you can see, probably less than 45 years of age is the #1 cause of death. When the explosion of construction activity, trauma and injury was the #1 cause of death overall in Qatar, unless we establish and mature the trauma system. Why? Because we didn't have a lot of injury prevention, we didn't have a lot of education for the public. Then the patient was increasing in volume, in injury severity score. They were becoming sicker and more injury requiring critical care service. At that time, we didn't have enough ICU bed, and also we didn't have enough professional, educated, and trained doctors to take care of those injured patients. There was a shortage trained doctors in the critical care, and now it's in the United States, they have the shortage. Also in Australia. So it's a global, really epidemic about the shortage of doctors. Also, from covering healthcare, you can see the leapfrog and all the benchmark and quality. We know if you don't have a trained doctors, you cannot provide good care. Now, there were other reasons. And the other reasons are Qatar was engaging in many global activities, especially high-risk activity like a motor Grand Prix. We have a lot of injuries from there. Also, we were involved in the FIFA Arab Cup. Also, we got the announcement that we were involved in the FIFA World Cup issue also. We were involved in Formula One. We have to be prepared with the trauma team to cover all of this spectacle. And then the pandemic hit us. One of the benefits that the fellowship really showed to the authorities is that we didn't have to hire a lot of people with intensive care training. All our fellows were displayed to the hospital for COVID, to the ICU. We established a 1,000-bed ICU because we have almost 3 million population of construction workers. They were young, but a lot of them, they were sick. A lot of them, they have comorbidities. A lot of them, they were chronic smoker. And the first and the second wave, if you remember, was a really devastated disease. It's not the COVID that we see right now. Also, let me see if this works. You know, we were embarking in producing 18 big stadium, train stadium, completely rebuild the country, you know, with 3 million construction workers, the highest risk, probably, profession that you can have. There were a lot of injuries. Then you know that all the cameras, all the radio were in Qatar because FIFA World Cup has by far the greatest, you know, the greatest fan base in TV cover rates than any to provide, you know, a chance of surviving any patients with traumatic cardiac arrest. And the fellowship was based by the American standard, or the accreditation college graduate of medical education in the United States, and 6 major components: in patient care, medical knowledge, practice-based learning and improvement, interpersonal communication, professionalism, and system-based approach. And everybody has a little component, plus we added 2 extra components. First of all, proficiency in the procedures. Most of our staff, they were not trained in critical care. They needed to know how to do minimal invasive monitoring, intubation, tracheostomy, percutaneous endoscopic gastrostomy. All of these things was done in the operating theater or operating room. All of this now is done in the ICU, saving millions of dollars to the institution and comfort to the patient. Because it's not easy to transfer a patient to the operating theater when we can do it in the OR. You really avoid the risk, you avoid the mishap, and you avoid the excuse to the family. Oh my God, the lines went off, the chest tube went off, he developed tension pneumothorax in the middle of the elevator. All of these things is completely an incredible, a safe environment for the patient. Then we invest in professional development to all our staff. When I have there, no staff was promoted. Now every staff in the last 15 years has been promoted to associate consultant or consultant. The next promotion will be Dr. Faith, because he just arrived from Australia and is going through the paperwork. But this is what it is. You have to give the credit to the people that serve your country. And this is me as a program director or leader of the program. This is what the professional and personal responsibility to society and to all of you. The aim was to enhance the patient safety, medical and professional satisfaction through the introduction of the Advanced Accreditation Council Graduate Medical Education, a structural trauma fellowship. I'm sorry, the slice is going, crazy, but I'm trying to stop it from here. Fellowship program in Qatar. We have to build a program with local and regional existing human resources. We didn't have time to import people from from Canada or United States or Australia. We couldn't do it. We have the tools, we have the passion, and we have the expertise to provide the best trauma care in the world. And we have demonstrated that. And those are the components that I mentioned to you. In physician management, we have to measure subcomponents. In the multidisciplinary team, daily rounds, teamwork, quality issues. And the quality process, the protocol, that we have the resources, we have one-to-one nurses, and so forth. We have family care. And then the program performance, I will show you what happened. In the first part, we have a lot of gaps and provide, MD training, critical care training, fellowship training to the patients. And after, 2 years of the fellowship, we really cover, as you can see, the second column and the third column, we cover these really major issues in quality. We established more protocol, and by the 5th year of the 40 doctors that we have, 40 trauma surgeons with critical care component, all of them has been trained by the fellowship. Some of them have done advanced training. As an example, Dr. Faith went to Australia. Some of them has done in the United States. And in reality, we try to provide different issues. As you can see, 55 doctors has been trained and through the program, providing an incredible satisfaction for them and patient care to the patient. And this is our result too. After the trauma critical fellowship, our in-hospital mortality has decreased enormously. And this has been demonstrated, not by our report, because I'm biased, it's my program, it's also in TICWI. We have the best performance trauma center in the world at this moment by this approach of the trauma quality improvement program of the American College of Surgeons. So this is something that I think we are proud of that, and I invite Sri Lanka, the authority, or any other country, to come and visit us and see and can learn. Because usually I think education, like anything in life, is a two-way street. We learn from you and we learn from there. We have established empty rounds, during the COVID, no COVID. We utilize the technology to the maximum included, as you can see. In the middle is our hybrid OR with this CT scan can provide CT scan to 2 patients in 2 different operating theaters. So this is something that really makes us better and more efficient. Instead of transferring a patient, and we can do it quickly right there. And this is the same thing that I just provide to you, that I'm going to, for the sake of time, I'm just going to make it to 7-minute presentation. That's why we can catch up with the timing. What is Advanced Trauma Fellowship has provided to us? It has provided a clinical service with 24/7 trauma and critical care trained physicians. 60% of physicians are European board certified intensive care medicine. Has significantly, sorry that it's moving by itself, has significantly contributed to patient safety and outcome in the critical injury patient. It has reduced the intra-hospital trauma-related mortality, as you can see in the graph, has decreased hospital length of stay, has provided critical care service around in any circumstances, including the COVID, and has additional benefit. It has enhanced the overall performance of our trauma service. Why? Because we have provided critical care certification, and also we have provided an increased echelon in the professional development of those countries. And we have established international fellowship for the MENA region, for Canada, for Sri Lanka, to the Philippines. Cost, we have enormously saved millions of dollars to Qatar because we have trained and it's approved our trauma trained intensivists, and we have decreased the OR utilization and procedures that normally was done in the OR. And without that, this is our trauma critical fellowship. It's done by surgeon, but we train also anesthesiology that I invited. I have invited a couple of them here. We train also emergencyology in trauma and critical care. It's approved. You can take the European board. With the EDIC, you can go and work in Europe and work here, and you can ask your boss to promote you because you're going to have an incredible certification from Europe. Okay? We have been awarded excellence in the MENA region and also for the American College of Surgeons. And this is our trauma critical care. It's take a village. It's take really a family to provide all of this. So quality performance has been improved. Clinical competence has been improved for our staff. And again, I'm going to invite you to beautiful Doha in Qatar, November 12th to 14th in 2026 for the Qatar Health Program, the World Congress of Emergency Surgery, and the World Congress of Simulation for medical students and nurses. Medical students and nurses, and we can provide an important information later. And without that, Bohoma is tutti. Thank you.
Thank you very much, Professor Peralta, for sharing your experience. I'm very sure that it would be immensely helpful to uplift the trauma care in our country as well.
Yeah, Prof. Jeremy.
Let's try this again. Oh, look at that. Here we go. Yeah, so I'm just going to spend the next little while just to talk to you about the importance of standardized processes of care. You've heard things like protocols and standard operating procedures being thrown around in trauma a lot. And I think what I'm hoping to do is to convince you that these are really important, particularly in trauma. The question as into why they're important is really the fact that when you have a complex, very unwell trauma patient, you have lots and lots of decisions and inputs that are coming through that you have to work out what the priorities are. And I think that we have the criticisms in general about standard operating procedures, like that protocols are a cookbook medicine, medicine is an art, that, a lot of doctors say, well, in my experience, I've done it this way. And, for the juniors and the trainees, they say, Dr. So-and-so has always done it this way. And so that's kind of like the basis of what a lot of medicine has been. I think that one of my mentors in Seattle, Ron Mayer, at Harborview, wrote in his presidential address that basically he said that the safest thing for Seattle would be for him to be on call 24 hours a day, 7 days a week, 365 days a year, right? We all think that we are the best at it, but the practical aspect to it is that as an individual surgeon, you can't be there looking after every single patient. So you've got to work out better ways of doing it. The other issue is that we're actually not as good as we think. Like, we all think we can identify a patient that's bleeding to death. And this was a great paper out of the Prompt group and sort of led out of Texas. And they looked at really the 10 level 1 trauma centers that participated in it and asked these attending surgeons about whether they thought a particular patient should have a massive transfusion. And guess what? They're not very good at it. They're about 50%. You can see that, like, you may as well flip a coin when a patient comes in, when you're looking at it. Like, we think we know, but actually we don't. In this quality of care in Australia, this was like a nationwide kind of investigation and audit into adverse events in healthcare. And really, more than half of all the adverse events that occurred in healthcare were due to cognitive failure on the parts of the clinician that was involved. And so these are associated with a high degree of preventability, and they also, more importantly, cause significant disability to the patients. And so the recommendations from this, you can see that almost a quarter of these adverse events could have been prevented if there were new, better, or better implemented policies or protocols, right? That's really important. The reason why standardization is important is that variation in care results in errors. And if you have these errors in care, that results in poor outcomes. So therefore, standardization of your approach to the patient actually reduces this variation. Basically, when it comes to trauma, it's a bit like playing poker. It's like going all in all the time, because you can only choose one or the other. You reach critical decision nodes and you have to make a decision. Standardization actually puts the odds in your favor and means that you're more likely to win. What's the benefit? Well, hopefully there are some of the ATLS colleagues still here. I mean, we all know the story about ATLS, and that's a global system. Interestingly enough, there's not really a lot of data about the impact of ATLS in terms of patient outcomes, but this is one particular study that kind of looked at the pre and post implementation of ATLS within a system, and they found that there were less deaths within 60 minutes, right? So that early period, which kind of like goes to the point of what ATLS is about. My colleague, Dr. Fitzgerald, who was here, I'm not sure if he's here now, actually a while ago now used a computer-assisted decision-making tool. So these are like prompts, like at the resuscitation bay, that would then step a clinician through the next steps when assessing and intervening. And they used this program and they actually tested it in a randomized fashion. And what they actually found is that by using this computer decision aid, these algorithm prompts, so that it was standardized, it reduced the, it increased the error-free resuscitation significantly, right? So 21.8 versus 16%. So there is benefit to that. This is a great paper out of Dallas that looked at the effect of following processes of care. And what they did is that if you look at them, they had 25 processes, and these are all standard things that we all do. So for example, one of the processes was, say, a patient with blunt trauma who had a GCS of less than 15. That process required that patient to have a CT scan of the brain, right? And so they looked at all of these patients, and they looked at the processes that would apply to that particular patient. And they kind of said, well, how many of these processes were followed, right, for that particular patient? They looked at about 1,000 patients or so in their center. And really the important thing is that they found that the more processes that were followed, right, and applied to that patient, the better the outcome. So they came up with this compliance score that a 10% increase in their compliance score resulted in a 14% reduction in mortality. That means if you do the same thing for the patient every time, you're going to improve your outcomes. They extended this to a multi-center trial, right, a few years later. They included like 5 level 1 trauma centers across the US, and they looked again at these standard processes like what we do. You know, for example, a patient who's hypotensive following injury, right, requires blood resuscitation. That was a process. And they looked at these sorts of processes and applied it and saw how many actually complied with it. And they found that really, again, there was an effect of compliance on mortality, right? 10% increase in compliance, 14% reduction in mortality, same sort of values. So this is across multiple centers now, right? Optimal care, so if there was 100% compliance with all the processes that were applicable to that particular patient, the risk odds ratio of dying was 0.42, right? That's a very significant reduction in the risk of mortality. This group out of the Netherlands looked at the effect of applying standard operating procedures or processes of care within the resuscitation room for patients with multiple injuries, and they really found that these standard operating procedures, if they were followed, resulted in a faster time to the completion of life-saving interventions, a faster time to CT, and a shorter time in the resus room. So all of these processes actually result in better care and more efficient care. This particular paper came out of the GLUE grant, which was a big prospective observational cohort including 7 level 1 centers within the US looking at very severely injured patients. And really what you want to look at is that they published a set of standardized guidelines and processes that each of those centers would follow for particular aspects of care of the trauma patient, right? And that was at the setup of the study so they could compare them meaningfully. And they had things like how are you going to manage a ventilator-associated pneumonia, what is the VTE prophylaxis, what's the nutritional kind of supplementation for these trauma patients. And what they found is that when they looked at the compliance between the first year and the last year of the study, there was an increase, right, in the compliance to most of these processes. And the amazing thing is that when they looked at the outcomes over the time, the mortality dropped, right? The mortality for these patients, same injuries, dropped towards the end of the study. When you look at the expected outcomes, so the predicted outcomes, which is the dotted lines, right? You can see that the solid line, the observed mortality, was actually lower than what was expected and predicted, right? And so they actually put this down to compliance with that continued compliance to the standardized processes of care. So I'd like to pose to you, like as in, what is trauma management like in your own institution, right? I just call it BBM, belief-based medicine. You know, I believe this patient needs this. Is it experience-based medicine? Or is it silo-based medicine? Well, we'll get someone else to decide. Let's just ask someone else. So the neurosurgeons have said to do this. Okay, they've just said it, so we just believe them, right? I think that it's really important that you try and standardize that with all those groups there. And what we did at my institution is that, and this is freely available, so feel free to look on the App Store or the Google Android store. It's all free. These are our clinical algorithms. This is what we use and what all of our hospital uses in the approach to the trauma patient, right? And we published this, and if you want more details, that's the reference there that I wrote about how we actually designed it and how it came about. And it's now been in use now for over 10 years, these standardized processes that are on this algorithm and on this app, which is easily accessible. We measured the effectiveness by using what's called this qualitative care score, which was taught to me and was what utilized at the University of Washington in the US, and which really looks at whether there was a variation from the standard, and then if there was a variation, what the outcome was. You know, was there an effect on the patient, right? And it goes from 0 to 5, 5 being dead, 0 being no variation. And so we kind of looked at the compliance with our rib fracture, high-risk patients, as well as thromboprophylaxis and the time to a spine plan and or clearance. And when we mapped it, you can actually see, so 2014 is when we introduced the app and like we had it freely available. You can see that the compliance actually progressively went up, and we're pretty much close to 100% for those 3 examples, right? Towards the end, it didn't take long. And when you look at the adverse outcomes that occurred, what you want to look at this is that actually the thing that changed was that before the app, before these standardized processes, there were a lot of like adverse events that resulted in extra care to the patient being required. After the app, there was less, right? They followed it. Yes, adverse events still occur, but they were actually reduced. So I guess in summary, really, what I hope that has been demonstrated is that these standardized processes of care, particularly in trauma, improve patient outcomes by reducing variation. I think specifically in trauma, because there is so much complexity in terms of the input and the timeliness of decision making, that I think that standardized processes of care are essential. I think we've demonstrated that compliance with these standardized processes actually results in tangible improvements in patient outcomes, which is really important. And the bit about implementing processes of care, you already have them. You know, it's available with ATLS, it's available like with your own standardized protocols. It doesn't actually cost very much to implement it. But what you need to do is like actually have the commitment to standardize it across your particular practice and your institution. I won't say that it was easy, like for us, but we did it, and now it's standardized. Now at every resus, they use the app to check. Like our juniors, doesn't matter whether they're from emergency medicine, trauma surgery, orthopedics, they all have the app. They all check. That means everybody's on the same page. This patient is going to CT next. They're not going to the operating room. And so that's the sort of the example that we've found in terms of the benefits, and certainly our outcomes have improved from like this standardization of care. This is just in closing, this is from that quality of health study that I alluded to earlier in the presentation from Australia. There's a need to design safer systems for care which protect the patient from human error. Like the safest thing for cars on the road is to not have humans driving them. I'll put that to you. These systems should provide new policies and protocols and technological support to aid the cognitive activities of clinicians. Thank you very much for your attention. Happy to take any questions.
Thank you very much for that very informative lecture. So our next speaker is going to be Dr. Sajith Ranatunga. He's a consultant surgeon at Accident Service, National Hospital, Colombo.
kind interruption that the oral presentations are now commencing at Hall 4. So oral presenters can go to Hall 4. Thank you.
Dr. Sajith Ranatunga is member of editorial board of the Trauma Journal of Sri Lanka. He's going to talk on major trauma destination policy. Over to you, Dr. Sajith.
Thank you, Sanjeev, for the kind introduction. Okay, so I think even yesterday, Jeremy Shu, I think make my life easier. He gave most of the point that from his experience regarding the selecting the destination. So okay, so just to get an idea why we should need a destination policy. So if you get global wise, it's about almost 2/3 of deaths occur in pre-hospital setting. So in that case, if you happen to reduce deaths, then you have to think something which either you should, in case if you can prevent, that's the best. So if not, then you have to think at least where the optimal transportation or pre-hospital care improvement. So that I think we are not discussing about the improving pre-hospital care. So now we will see what we can do when we change the the policy of how the major trauma will be transport. So it's the, as Jeremy Shu yesterday mentioned, is right patient to right place at right time. So you select the correct patient and you select the place the patient should be landed, and then time critical. As you know, we call golden hour of trauma, and even minutes and second counts. So I don't think I have to go into detail. I think we have live examples. So Prof. Jeremy will be, he will say that this is definitely yes. So it's international evidence confirm major trauma cases likely to have better outcome if the patient is transported directly to advanced level trauma center. So this actually speaking, it has been started in, implemented in from the suggested, accredited by the American College of Surgeons in 1987. And most of the developed countries now, it's their own destination, major trauma destination policy. So what happens in Sri Lanka? Actually, in Sri Lanka, I think country to country, we see the difference between injury, as Qatar's teams, they have more, construction sites, they have more injuries, they see more injuries. But in Sri Lanka, what we see is most of the deaths are from the road traffic accidents, and most of them are motorcyclist or pedestrian related to even the motorcycle accidents. So then, and then majority of them die of head injury, especially when they have polytrauma, but their main cause of death is head injury, even though that as Thailand couldn't do what we have done, where we have implemented helmet, but still having had helmet, but because of the speed and the other factors that we see significant head injury where patient die of. And then when we get neurosurgeons in Sri Lanka in government sector, that we mainly they are situated in National Trauma Center, and then other places are in teaching hospital, where we have one in Karapitiya and one in Central Province Kandy, and then Anuradhapura North Central, and the Northern Province we have in Jaffna and the Batticaloa. So and then others are in private sector actually. So when you consider now usual transportation, at the current consensus that we don't have separate major trauma destination policy at the moment, and then current policies where you usually transport to the nearest hospital. If from the free hospital setting, when then nearest hospital will transfer either after the initial investigation like CT scan, and then transfer to the place where neurosurgeon is available. So we have ambulance service, government-led ambulance service 1990, and then they usually, their policy is to send the closest hospital possible, even the patient request. And then, but if you see the low count in the blue line, that is actually last week statistics, how mode of transportation to accidents, National Trauma Center. So if you see pre-hospital care ambulance, only 75 patients, and then other transportation, that like their own vehicle or other vehicle transportation is 1,577. So if you haven't, that is even less than 5%. So then the question comes, if you are not amazed, you can amaze that then question comes to prevent, or the improve the the patient's condition, then most likely Sri Lanka might have to train not the the designated emergency medical team, probably the public. So because in Sri Lanka, public will not wait until ambulance come, because they are whenever they see injured patient, they will quickly take the patient to the hospital, thinking that they will do a good. It's on good faith actually. And the hospital we have ambulance transportation. Okay. So then comes what we have actually even been late. So we have got some, the major trauma destination policy, inter-hospital transportation will be implemented soon. So this what happened was actually one of the incidents where one of the young male transferred from one of the tertiary care center after the CT scan, and then there was some apparent delay, so the incident reported to the Dr. Jagore, and then it was observed, and then we analyzed, and then there seems to be some delays from the incident, where incident happened, and then patient was backwards gone into the closest hospital, and then again retransferred to the place where in the national hospital, and then that triggered to search. Anyway, we were observing that there were some couple of incidents where that we could have saved some time if the transportation was all right. And then that same week, when we analyzed the number of deaths from head injury, because majority are head injury, and then to realize that all the all the patients who had died at that particular week was all are transfers, not the direct admissions, 100%. And then that triggered we were discussing, but to at least try to implement to prevent further deaths. So then it went up to the Director General level, and then we at least to start inter-hospital transportation policy. And then just to get, then the problem comes, now we need to know what is major trauma. Then the facts we should know, it clinical and other parameters, it comes as physiological, anatomical, and mechanism of injury. So then actually what is shown is actually taken from the New Zealand inter-hospital transport, major trauma transfer policy. It shows, I don't know whether you can appreciate it, it has blood pressure, heart rate, and then respiratory rate, saturation, and GCS. Because it totally, I'll go after I'll discuss this about pre-hospital but bit later. So this actually mainly from his hospital level we can check GCS. That is a physiology. And then rest, actually this is what we have developed but not implemented yet. Soon we are going to. And then if you see the green color one, that is the anatomical part. When you have a head injury, like you have open depressed skull fracture, and then we come to neck, like cervical cord injury, like paraplegic or quadriplegic, and then and chest, abdomen, every place where specifically we identify anatomical injury which can taken as major trauma. And then third part in orange color is mechanism of injury, like if you get fall, not only the road traffic, everything, when fall from more than 10 feet, and then speed of the vehicle, and then if the incidents where other passenger is dead at the scene, like you get parameters separate. So it include first one, major one, most important physiology, and then comes the anatomy, and then comes the mechanism of injury. So we to implement that, we have got things from other countries, actually Australia and New Zealand, and then some other countries. So so we got things into it, and then actually this is we haven't done it yet pre-hospital, because it seems that we have to struggle, to do a lot of workout for that. This is American College of Surgeons Committee of Trauma. They have implemented field triage of injury patient. So they have red criteria and yellow criteria, where a field emergency medical attendant can go through that. Then you mainly consider where you can assess things which can be identified easily, like similar to the inter-hospital one, but which are very simplified version where they can easily identify. And then the yellow criteria comes where you don't have it. In case red criteria, then you ask the team to directly go to the best possible trauma center. And then when it comes to yellow criteria, it has to be relevant, but it hasn't to be the best one. Okay, so this is actually a algorithm. I don't know whether you can appreciate. So initially what happens is you get the injured patient and then do primary survey. So it's very important all the staff, who are going to assess at the first contact, to have well trained in primary survey, and then identify the red color comes in the physiological, as I discussed initially, that red color comes the physiological parameters. And then if they say yes, then you directly go and discuss with the major trauma center. And then if they are not there, then you go and see whether green color, it comes the anatomical factors as according to the field. And then if they are not here, then we go and see whether there are any mechanism of injury which are relevant to major trauma. And then according to that, then you discuss with the, in case if the center where the treatment initial center can manage the patient, it's fine, then they can manage. If they can't, then they have to contact major trauma center. When you contact, better have telemedicine conversation ability, then you can prevent most of the unnecessary transport, because then we know what are the factors properly, and then the advising team can easily say if it is not necessary, then it's not necessary. So what we should do, so implementing guideline, at least first, as we have discussed, inter-hospital transportation will be implemented soon. And then I think we have to work a lot for the next level, like pre-hospital one, because as I said, I think we have to train first contact person. Actually, we are trying to develop simplified resuscitation and version to train general public. Because we have a lot of tuk-tuk where they are the one who see most of the injuries, so that if we can train them to stop bleeding, so we should be able to get the good outcome. And then in improving infrastructure, actually, even if we can get, because we are now running, actually because of the migration and things, we now getting less and less medical staff, and then so at least we can improve transportation, then like aeromedical transportation, then probably we might be able to improve the outcome of the patient. And the most important thing, like as I said, training and assessment of first contact person and the primary care institute. Already we have gone into the peripheries where primary trauma care with the primary trauma care program, because that's one of the important thing to prevent injury. Initial treatment is the most important. And having a hotline like Australia, they have 000. So we are discussing about getting at least for the National Trauma Center a hotline, and then telehealth consultation like a commanding center. So those are dream actually. Most likely we should be able to get, and then the most of the important thing, I think, evaluation of progress and make the changes as Prof. Jeremy said, we should not think that we are always correct. We should always have a mindset to change if it is necessary to change. Okay, thank you very much.
Thank you, Dr. Sajith, for sharing your first-hand experience with us. So that would conclude the session. And